We were highlighting the problem of rapid readmissions, which is when patients are discharged from hospital and they are readmitted within 30 days of their discharge. To us, that's a failure of coordination of care and an ability to really understand why the patient continues to come back to hospital so soon. So in this presentation, we were looking at how do you design interventions that will keep patients out of hospital, because there are huge personal and economic and social costs to individuals continuing to return. One of the things that we found was that there's a huge discordance between what clinicians think is the problem and what patients themselves identify as the cause of them coming back to hospital. So what we were hoping to highlight in this presentation was that if we take more patient and family-centered approaches, which means understanding patients' perspectives on admission causality, we can design interventions that are better suited and more acceptable to them to keep them out of hospital. We have included patient advisors as members of the collaborative treatment team who can share their lived experience with patients who are admitted to inpatient unit and participate as members of a team who are able to sit in family meetings, help facilitate discharge, help the patients and families understand what life will be like after discharge. What's happened is that our professional cultures have shaped us in ways where we've become very, for better or worse terms, biologically reductionist. We look at issues that are surrounding medication adherence, for example, and we say, well, that's the problem, they're not taking their medication, or they didn't show up to the program, or, so we have our sort of our task list that we've been set out and have been trained to check off when we send a patient home. And what we find is that our professional cultures have narrowed our focus, so much so that we don't see through the patient's eyes. We don't understand their lived experience. We don't ask them why they think they're there, what they think would be helpful for them. We take the expert role, and what we have to recognize is that patients themselves have expertise in their lived experience. We have opportunities to design interventions that are acceptable to them, but we make the assumptions that we know what is acceptable to them without asking, or without including patients as partners in their own care. So if we work collaboratively with patient partners, we can include them in the discharge planning discussion. They can help highlight what we're missing in that discussion around what will be feasible to the patient after they leave hospital. We can, for example, say, okay, we'll see you in the day hospital program after you go home. And the patient advisor may say, but wait a second, who's going to get them there? And who's home to bring them there? And how difficult will it be? And do they have transportation? And are these are the questions that we are missing as clinicians. The benefit is that patients feel as if there's a sense of hope and autonomy for themselves. There is a promotion of a sense of recovery. Patients who are included in their own treatment plan feel more empowered and take that sense of empowerment outside of the hospital, and so they can become more autonomous and pursue their own recovery. From an organizational perspective, the economic burden of readmissions is huge. The hardest part, really, and it is hard, is changing culture. Because in my presentation I talked about how culture eats strategy for lunch. So we can have the best laid plans, but if there really isn't a commitment to cultural change within our professional bodies and within the organizations that we work in, this will never happen.